Hello all, thank you for joining. We'll give it a few more minutes to allow more attendees to sign on. Thank you. We'll give it one more minute and then we'll get started. Thank you all. Great. Good afternoon, everyone. Thank you so much for joining our CCHP Quarterly Provider Network Training. Happy New Year. Welcome to quarter one. We have a very exciting provider network training planned for everyone today. Would someone be able to share the slide deck, please? Hi, Sir Aaron.
I've got that.
Thank you. Great. Next slide, please. First, just wanted to go over the agenda for this afternoon. We'll first have a public health update from Dr. Meera Srinivasan from the Contra Costa County Public Health Department. She is the Deputy Health Officer and works as the Communicable Disease and Tuberculosis Controller. She'll be providing us with a public health update. Separately, our CCHP team will be providing information on our CPT code search tool, the service level authorization project, and then Medi-Cal prescription benefits, clinical practice guidelines, and potential quality issues. So a lot on the plate today, and we'll try to be mindful of time and ensure that we get you guys out of here no later than scheduled. I'd like to first turn it over to Dr. Meera Srinivasan to provide her presentation. Thank you so much for joining us today.
Of course. Thanks, Irene. Can you confirm you can hear me okay? Okay, great. Hi, everyone, and thanks for having me. I'm happy to be here to hopefully inform you about some things going on in public health that are timely right now, specifically going over what's happening with our respiratory virus season, updating about avian flu, and then some things regarding tuberculosis. Next slide. Thank you. So currently with the current respiratory virus season, we're primarily talking about the three main viral pathogens: influenza, RSV, and COVID-19. And the key take-home messages right now for these viruses from the California Department of Public Health and also locally are that the influenza activity is increasing, and I'll show you some data shortly about that. RSV activity is moderate, and fortunately, COVID-19 is continuing to be low for this respiratory season. With regards to influenza, we're seeing primarily influenza A, both H1 and H3, and not so much influenza B. And that, unfortunately, what CDPH data is showing regarding vaccination is that only a small percentage of eligible Californians have received the appropriate respiratory virus vaccines. But it's still not too late. I'll be going over that message again. It's definitely not too late to vaccinate our patients. Certainly, this is our key prevention tool to prevent severe disease and also try and help with controlling the spread of these respiratory viruses. Next slide. So this is state data regarding COVID-19. This comes from their laboratory surveillance data looking at basically positive results through their electronic lab reporting surveillance system. And it's comparing the current season, which is in the blue kind of line with the dots. That's the current 24-25 data, looking, basically a whole year's worth of July to June. So covering the current respiratory season, comparing it to the prior two respiratory seasons. So in green, you'll see the 23-24 season, and in kind of the orangish red color is the 22-23 season. And interestingly, for this season, we certainly all experienced and saw the spike that happened over the summer. But interestingly, this winter season, we're not seeing a similar spike that we've been seeing since the start of the pandemic. What that means, we still don't know yet. Maybe we will see another, maybe an early spring spike. We know this virus really loves when humans congregate. So more to come, but just to be aware, right now, we're not seeing a lot of COVID-19 activity. Next slide. Next slide. And so what we are seeing a lot of is influenza. So this is a similar graph, except going over influenza data. Again, the current season is in the blue, and you'll notice that it is probably, knock on wood, about to peak and come back down, but we haven't seen the peak yet. It might be more of a bimodal peak, we'll see. But comparing this to the prior years, of course, the 2020-21 season, we didn't see any influenza activity when we were in the heat of the pandemic, but we did see an increase. 22-23 was slightly more severe, and then the 23-24, which is in green, we're kind of tracking that this year, but we are seeing more flu right now, but every flu season is unpredictable. So I think it's still, the messaging is flu's around, flu activity is high right now. So consider flu in your patients presenting with respiratory illness. And if they haven't been vaccinated, definitely vaccinate. Next slide. And this is what RSV looks like right now. RSV has traditionally had an early winter, late fall distribution. Right now, we're seeing it increase, but starting to come back down. So it kind of slightly off this year, but still not as bad as prior years. Again, the 2020-21 season really shut down RSV and flu because we were taking care of COVID-19, which also took care of these other respiratory viruses. So RSV activity is coming down, but certainly can still be considered, especially in your high-risk patients. Next slide. What else is circulating right now? Those aren't the only three. We certainly have plenty of the common cold viruses like rhinovirus, enterovirus, adenovirus. So if you've tested for flu, COVID, RSV, it could very well be some of these other viruses that are circulating. Next slide. I just wanted to show this slide, which goes over death certificate data to show kind of who is just, really drive home the point of who is at high risk of severe illness. And it is, our elderly population are 65 and over, have, unfortunately, they continue to experience the most severe illness and unfortunately continue to die from all three of these pathogens, COVID-19 on the left, flu in the middle, and RSV on the right. We have had some pediatric deaths as well this season, unfortunately, from flu, RSV, and COVID-19. Next slide. So take-home message for these three: it's not too late to vaccinate. And what are the current recommendations, which I'll show you on the next slide. So anyone 6 months and older who's eligible should be getting the COVID-19 and flu vaccine. Keep in mind, there is a second dose recommendation for elderly for COVID-19, as long as it's been at least a 2-month interval from their last shot. RSV, there are obviously two groups that we're trying to protect against here. One is to protect our infants, so we vaccinate our moms. And if we can't vaccinate our pregnant moms, then we try and vaccinate the babies. And then, of course, our elderly population, this is a slightly new recommendation. This vaccine, of course, has only been around, this is its second season. And so now everyone over the age of 75 should be recommended this vaccine. And then if they're in the 60 to 74 age group, it should be based on if they have risk factors. If they received the vaccine last year, they do not need another dose. The thought is that the vaccine will last at least 2 seasons, so more to come for the 25-26 season, but these are the recommendations for this current season. Next slide. And so also keep in mind that treatments are available for COVID-19 and influenza. If your patient is obviously, and they're in the outpatient setting, oral antivirals are available for COVID-19 and flu. These treatments are most effective when initiated early. And if you do have a high-risk patient, then you definitely should be encouraging them to get tested for all three. But certainly we have treatment available for COVID-19 and flu. And if you're suspecting flu and you've tested, you do not need to wait for the result to initiate treatment. Unfortunately, we do know that individuals really are not aware, and some of our high-risk groups are not getting tested. So the more we can promote that, the better. Next slide. So I was going to move on to avian flu, and I was thinking maybe for questions, since we have a jam-packed agenda, if you want to just put them in the chat, and then I can review when Dr. Lowe is presenting and try and answer in the chat. So avian flu, I'm sure you've been hearing, hopefully you've been hearing about it in the news. Just a quick background about it. So avian flu is specifically the H5N1 influenza A virus. It's often referred to as a highly pathogenic avian flu, but it's referred because it's called highly pathogenic because it's highly pathogenic in birds, not in humans. And so this virus was first detected in California in 2022 in poultry and wild birds. The virus itself has been around since 1997, however, was primarily limited to countries in Asia. So in 2022 is when we started to see it in the United States. And then over the summer in the United States, first in Texas, it was started to be detected in dairy herds. And as California is one of the largest dairy producers in the country, the Department of Public Health here started partnering with our state, federal, local partners to really prepare for introduction of this virus into dairy herds, as we knew it was coming. Locally, we've done an assessment. We do not have any commercial dairy farms in Contra Costa County. We do have backyard flock owners. We do have commercial poultry farms, and we know we have avian flu in these situations. We do have detections in our backyard flocks. And I'm sure when you travel the county, you see cows everywhere. I do, but these are not commercial dairy cows. We've thought about how could this be introduced? Why would we suspect it in our county? And I'll go over some scenarios where you should be suspecting it in your patients, because we did start to detect it in our dairy herds in August. The thought was learning a lot about how cows are moved around in this country, but basically this was due to importation of herds, not because it was a new spillover event or species crossover situation. There were detections initially in Central California, and then more recently at the end of 2024 in Southern California, and the governor did declare a state of emergency to allow resources for us to respond. The first human case was detected in California in October, shortly after it was detected in dairy herds. Next slide. So I know there's a lot of words on this slide, apologies, but just if you are distributing the slides, just so you have it, currently there are 38 confirmed cases in California. 36 of them have all been due to exposure to in workers to dairy farm situations. So these are dairy farm workers. The other two are pediatric cases, and those were detected through routine influenza surveillance. So we're not sure of the exposure. The exposure at this point is unknown. Fortunately, everyone has experienced mild illness. Conjunctivitis seems to feature prominently with this virus. No one, there have been no deaths, there have been no hospitalizations. Patients are responding to oseltamivir, and that continues to be the case. And there really has been no reported human-to-human transmission. The last known documented human-to-human transmission of this virus was in 2007, and that was in another country. So the treatment recommendations are to if you first of all, if you suspect H5N1, in the next slide I'll show you, you need to be reaching out to the health department, but testing is really important. And once you test, you can treat with oseltamivir, and that we are recommending prophylaxis for close contacts. So next slide. The other thing you might have been hearing about is a recall of raw milk. So this happened in November and December. The California Department of Public Health and Food and Ag recalled milk from 2 raw dairy milk producers. One was I believe in Fresno County, and the other one is in Stanislaus. But basically, the recommendation continues to be, which has always been, regardless of this virus circulating, is to avoid consuming raw milk and raw milk products. Not only you as an individual, but also you shouldn't be giving it to your pets, because there also have been detections of this virus in cats who've been fed raw milk. And more to come about that. But not only should you not be giving you should not be consuming raw milk to avoid H5N1, but there are myriad other bacteria and other pathogens we are recommending you avoid raw milk to avoid getting infected with those, such as brucellosis, E. coli, Campylobacter. Next slide. And so nationally, there have been 67 reported cases. There has been 1 death. This was an elderly gentleman in Louisiana who had exposure to wild, I think it was either a backyard flock or wild birds, but he also had comorbidities. That was not because of dairy herd exposure. Next slide. And so the overall message around avian flu among dairy cattle, it's an ongoing multi-state outbreak. In wild birds, it's widespread. In poultry flocks, they're sporadic. It's sporadic, but it's been around a long time. And sporadic infections in mammals, such as cats. There is no known person-to-person spread right now. And overall, the public health risk is low in the general population. Next slide. So you really should be suspecting this. So what are the scenarios in our county specifically where you might, as an outpatient provider, experience this? You know, we certainly have a big county. We might have individuals who work on dairy herds outside of our county, but live in our county. They very well could have been exposed outside of our county but present to you in our county. So anyone who is a dairy herd or poultry farm worker and has respiratory illness symptoms, you should suspect avian flu. Backyard flock owners, we have Lindsay Wildlife, we have animal control services. So any individuals who have these types of exposures, you should be asking about that and considering avian flu and testing if you determine that there is an exposure. Obviously, if they walk in and tell you, yeah, I know somebody who has H5N1 and I work on a farm where the cows all have H5N1, take them seriously and consider testing them. Laboratory exposure is another possible way to be exposed. Next slide. And if you suspect avian flu, then definitely reach out to us. We can provide guidance on everything on this slide. So how to test your patient, what to do with your patient, or how do you isolate them? What do you need to do to protect yourself? A lot of the exposures have been due to not having personal protective equipment on when either working or treating patients. And the other thing I just want to point out, if it's not clear, vaccinating actually against seasonal flu is important because there have been cases of co-infection with seasonal flu and H5N1. We do not yet have a vaccine against H5N1, and so seasonal flu vaccine might help reduce some amount of severity. Next slide. So just moving on to TB, I wanted providers to be aware of a new law that just went into effect in California. It's AB 2132. It does stipulate that all primary care providers in California are required to evaluate their adult patients for tuberculosis. So this is really like a screening law that has now gone into effect. And so the idea here is you would be asking about risk factors for TB exposures. So any close contacts, foreign-born status, whether they live or work in a congregate setting, unhoused individuals, persons living with HIV. And if they have a history of substance use or alcohol use disorder, these would be the risk factors for possible TB exposure. If you identify a risk factor, then please do screen them by ordering a TB test. Quantiferon is really the best test to order right now, especially if you have an individual who may have received the BCG vaccine. Keep in mind, the quantiferon will not have a false positive if prior BCG vaccination, if they've had prior BCG vaccination. And if their TB test is positive, please do a TB symptom screen, a physical exam, and a chest x-ray, because the number one thing you need to do next is to rule out active TB disease. And once that is ruled out, you can certainly offer them LTBI treatment. Next slide. There are a lot of resources and tools that are being developed to help healthcare systems implement this. This is just an example, and I'm happy to put the link to this in the chat about, 4 easy steps to preventing TB disease in our state. Next slide. And that is just to make you aware, World TB Day is coming up. It's every year on March 24th. On that day, we release our TB data for the prior year. This is what we released last year. And I think it's always important to keep in mind that, yes, we do have tuberculosis in Contra Costa County. We rank 9th in the state. Overall, United States is a low burden country. So you can see that in the US, the rates are anywhere from 2 to 3 per 100,000 population over the last 10 years. Those have remained pretty steady. We are a low burden country. However, our state is a high burden state. We have one of the highest rates of tuberculosis in the United States. That is shown in the blue line, anywhere from 4 to 5 cases per 100,000 over the last 10 years. And Contra Costa County is a medium burden county within California, and we track along with state rates, generally speaking, which means that we have enough TB in our county for us to be aware of it, to be thinking about TB when we have patients presenting with a cough that isn't going away, along with weight loss and night sweats and fevers and hemoptysis. Please be thinking about tuberculosis, especially if they have a risk factor for exposure. Next slide. And so to receive our World TB flyer, I just wanted to put this out there. We do have a way for providers to sign up for advisories and anything we release, and I'll put this in the chat as well. That's all I have. I wanted to be quick. Hopefully I didn't go over. Irene, I know you had a large amount to cover.
Any questions for Dr. Srinivasan? I think there's a hand raised. Aaron?
I was just clapping.
Oh.
Great presentation. I appreciate it.
Yes, thank you so much. If anyone has any questions, please feel free to put them in the chat. Don't be shy. We'll continue with the presentation, and if Dr. Srinivasan isn't able to stay on the call, we'll get those questions to her and get some answers for you in the near future.
Thanks, everyone.
All right, next slide, please. Oh, great. So I wanted to share with everyone an update regarding our CPT code search tool. You may have heard of us talk about this in a past provider network training, but this is something that CCHP has been working on for the past year, and we were excited to have launched this back in December of 2024. This is a web-based search tool where you, the providers, and your teams can either enter a CPT code or certain keywords to determine if a service or a code requires prior authorization from CCHP. There are certain services that will always request prior authorization, that will always require prior authorization for CCHP, but we wanted to create this resource for our providers so that way it'll be easier to navigate the prior authorization process. Prior to this, we had used something called the authorization matrix. This replaces the matrix. So consider the matrix retired. And feedback we had gotten regarding the matrix was because it was describing services kind of in a general sense, it was hard for providers to determine whether a specific code met the prior authorization need or not. So we're hoping that this tool will be much more useful. I will caution everyone that it is a work in progress. This is the first time we've launched this tool, so that we anticipate there will be hiccups. We already know that some codes are not included, and so this is something that we will continue to regularly update. And in the updates, we will ensure that feedback that we have gotten is reflected, and that we ensure that it becomes more of a robust database for everyone to leverage. Also, with the launch of this tool, we added additional services to no longer requiring prior authorization. So please check and ask your teams to check for certain codes to determine if prior authorization is still required. Next slide. So this pretty much summarizes what I've already shared, but I do want to highlight the links that are on this this slide. This link is to the URL for the tool on our website. There is also a more user-friendly direct link, but this is the general link to our authorizations and referrals department webpage. So it's a great place to start because you can find additional information there as well regarding utilization management at CCHP. Next slide. Just wanted to show everyone what the actual webpage looks like. So up at the top, you can see a box where it asks you to enter a 5-digit code, keyword, or description. And that's where you would enter your code or keyword to determine if it needs prior authorization or not. Also on the homepage, we've provided some helpful information and facts about CCHP utilization management in general. So that way you can potentially apply these rules when you're considering submitting a request for prior authorization. It also discusses our different lines of business, our networks, and also tells you what always needs authorization. And there are certain things that are always covered without authorization. Any questions on the CPT code search tool? Great. If there are any questions, please feel free to reach out to our CCHP utilization management team, and they'll be able to answer your questions or facilitate getting an answer to your question. Next slide, please. So now I wanted to share with everyone a project that we've been working on here at CCHP regarding service level authorization. Next slide. So this project was conceived and needs to be done really for CCHP to meet CMS's final rule on interoperability and prior authorization. So we are planning on going live with this authorization project later this I was going to say later this month, but likely February of 2025. And this requirement from CMS essentially calls for CCHP to restructure our Epic Tapestry system to capture service level authorization data as of January 1st, 2025. It'll also set CCHP up for success to improve our electronic exchange of healthcare data. So essentially what this project asks us to do is make a very clear distinction between referrals and authorizations, and also requires CCHP to approve or deny services at the CPT code and rev code level. And it will also allow CCHP to improve our methods for tracking authorizations and turnaround times. So what does this mean for you guys, the providers? The CCHP portal should essentially not change too much for you guys at the user interface. However, you will find that we will now have authorization numbers in addition to referral numbers to reflect that we are doing it at the authorization level and not the referral level. Any questions on that? Great. Next slide, please. I'll turn it over now to Dr. Joseph Cardinale to talk about Medi-Cal prescription benefits.
Great. Thank you so much, Dr. Lowe. Next slide, please. So what we're going to talk about today is some important updates to the Medi-Cal Rx program. Just a quick review of what Medi-Cal Rx is. It was issued due to Governor Newsom's executive order back in 2019, and what it basically did was took the Medi-Cal members' prescription benefits, moved it from the health plan to a single state controlled by DHCS program called Medi-Cal Rx. It originally went live January of 2022. However, they had some issues when it first started out with prior authorization requirements. So what Medi-Cal Rx did back in February of 2022 was basically suspend prior authorization requirements for all Medi-Cal Rx members. Over the past few years, they've been slowly putting those back in. Next slide, please. The last edit that they are going to put back in is prior authorization requirements for Medi-Cal members 21 years of age and younger. This includes CCS program members, and this is going to go back into place as of January 31st, 2025. Next slide, please. The caveat that Medi-Cal Rx has put into place for any new prescriptions, new therapies for a 21 years of age and younger Medi-Cal member for a Medi-Cal Rx covered medication, if it requires a prior authorization, it will reject at the pharmacy for a new prescription that needs a prior auth. However, if it's a continuing therapy where the system will look back, and if it sees that it's been a medication that has been previously filled before January 31st, they're going to give a grace period of 60 days. So providers will not get hit with a huge request for prior authorizations all at the same time. It's going to be a 60-day period, grace period, where these meds will still go through and will not reject with the prior authorization required. But we want providers to know that this is coming. Just be aware if you're seeing prior authorization requests for your Medi-Cal members for 21 years of age and younger, that you will see an increase in these. Next slide, please. If there's any questions, while CCHP does not control the Medi-Cal Rx formulary or prior authorization requests, we're always happy to look into issues for you and help you solve the issues. Great, thank you.
Thank you, Dr. Cardinale. Any questions for Dr. Cardinale? All right, seeing none. We also wanted to provide an update to you, our provider network, on our clinical practice guidelines. Next slide. So in order to support our providers, we collected some evidence-based clinical practice guidelines to ensure that you're able to continue delivering high quality care and, to assure optimal patient outcomes. So the guidelines we've put together really do cover a wide range of clinical areas, and a combination of our clinical operations team and our quality department regularly meet to update and ensure that these guidelines reflect the latest research and best practices. We encourage providers to use these guidelines to inform their clinical decision-making and enhance patient care. And just for reference, all these guidelines are reviewed and approved by CCHP's Quality Council on a regular basis. And CCHP's Quality Council is made up of CCHP team members, as well as physicians from our community provider network and our regional medical center network. So we really do engage our provider network in putting together these guidelines and ensuring that they meet our requirements and will be helpful to our providers. Next slide. So this past year, we really took it upon ourselves to refine our guidelines and kind of enhance what we're able to share with our provider network with regards to clinical practice. So historically, we had provided a few general links on, evidence-based guidelines as well as national and state organizations that may be helpful for unique diseases. We wanted to really make a push to really cover larger areas of scope and ensure that those who practice and care for specific diseases have access to information that is more specifically tailored for their needs. So what we've done is we've provided some general clinical guidelines, and now we've broke it down by specialty or disease type or disease process. So for example, this is a screenshot of what the first page of the guidelines look like. And as you can see, we have general guidelines as well as behavioral health. We also have cardiovascular, infectious disease, et cetera. We really wanted to cover the gamut of what our provider network does in care of our patients and our members. So we really broadened what our guidelines include and really do hope that you find this information helpful in your daily practice. This is also on our CCHP website. Please let us know if you have any feedback on these guidelines, if we're missing anything, if there's any other disease process or topic that we should include in future updates. Any questions on this? Great. Next slide, please. I'll next turn it over to Maggie Sosa to talk about potential quality issues.
Hello, everyone. Thanks for joining. Next slide, please. What's a potential quality issue? It is any deviation from provider performance, clinical care, or outcome of care, which then requires further investigation to determine whether an actual quality issue or opportunity for improvement exists. Not all PQI represent quality of care issues. We receive PQIs for quality of service issues as well. Next slide. Quality issue would be a confirmed deviation from expected provider performance, clinical care, or outcome of care, which has been determined through the PQI process to be inconsistent with professionally recognized standards of care. So anything that goes outside what's professionally recognized, then it would consist a quality issue. Next slide. And quality types of quality issue we can see system issue or a provider issue. A system issue could be, for example, a specific clinic or a specific provider doesn't have a specific policy and procedures to address, for example, medication refill. And a provider issue would be, for example, when a member reports they have a mass somewhere in their body and the provider just dismisses it without doing further testing or further evaluation of that mass. Next slide, please. How are PQIs identified? So we can receive PQIs from any person or department. For example, most of the PQIs we investigate are received from appeals and grievances. We also receive PQIs from utilization review, from claims, from care coordination, case management. Also, a lot of PQIs are identified by our FSR nurses when they do medical record audits. And I already cited facility site reviews, which is the FSR nurses. Also, members or provider survey can identify PQIs. And also from referral from other health plan staff, providers, and members of the community. So the motto here is, if you see something, say something. So anybody can identify a PQI. Next slide. Who can identify PQIs? Members, contracted, or non-contracted providers or staff, pharmacy providers, PHP staff, community members, hospital, SNFs, ancillary providers, DME, or medical supplies provider. Next slide. I have two examples here. Can we identify if they are PQIs or not? On the first one, a member alleged that the care he received from PCP was incompetent. The member states tests were ordered for him without an explanation. The member also stated he would be on a specific medication for life, but his PCP stopped the refills and did not explain why or provided an updated treatment plan. So what do folks here think? Is this a PQI or not? Can anybody answer to that? So in my opinion, this will require further investigations because the member could be, and somebody put in the chat, need more information, and that's what I do as well. Because sometimes we go over treatment plans with the patients, but they are so overwhelmed that they don't remember. So for this one, the first one, we would need to do further investigation to determine whether it's a PQI or not. Second one, a member presented to the ER with complaints of headache, dizziness, and arm pain. She was discharged home with a prescription. A few days later, the member returned to the ER with complaints of left upper body and lower extremity weakness with facial droop and pronator drift. She was later diagnosed with a stroke. Is this a PQI or not? What do folks think? I would say this is definitely a PQI. The provider most likely missed a CVA. Next slide. How you can submit a PQI? For members, providers, and community members, they can go to our website and complete a PQI referral form. After they complete the form, they can mail, email, or fax it to us. And for internal staff, you can send the form to qualityconcerns@cchealth.org. Next slide. Here's the PQI submission form. And if you can't find it in our website, please feel free to email the email address I provided there, and I can email you a form. Next slide, please. That's it for my presentation. Any question?
So Maggie, I was wondering if you could share with the providers on this call, if they are on the receiving end of a potential quality investigation, what does that mean and what would they need to do?
Okay, so if you are in the receiving end, it means that somebody filed a complaint against something that they didn't like or went wrong. We will then write you an inquiry letter. And the inquiry letter will address the points of the complaint. And we ask that you please respond to us. We give you 7 business days for you to respond to that complaint. And it is on your benefit to respond to us, because when we write you an inquiry letter, it doesn't mean that it was confirmed that you did something wrong or that you deviated from the standard practice. It means that we are giving you an opportunity to clarify what happened. As I said, sometimes the patient is very overwhelmed and they can't remember everything you told them. So this is your opportunity to clarify, and this is your opportunity for us to hear on your side, like what happened during that visit, what happened during that procedure, And then once we receive your response to our inquiry letter, we gather all the response and we gather all the evidence from chart review, and we present this case to the PQI committee. Then the PQI committee ranks that quality issue or quality of care. And if you receive a 0 or 1, that means you don't basically need to do anything. If you receive a level 2, we can issue a formal recommendation. Then you need to respond to us and we will tell you what you need to do. If you receive a level 3, it means that we issued a cap. Then you need to present us with the response to that cap. And both for the formal recommendation and the cap, you have 30 days to respond. And again, it is on your best interest to respond to us, so we can close the case and no further action will be needed. Any questions about that?
Great, thank you, Maggie.
Thank you,
So it looks like thanks. So it looks like we flew through a lot of our topics pretty quickly today. We have a few more topics we wanted to share with everyone, but we did want to kind of let everyone know that we are trying our very best to enhance this provider network training to ensure that it's meaningful for you, our providers, and to really make sure we present you with updates that we are doing within the health plan and also any regulatory updates that you guys need to be aware of as well. At the same time, we also want to take your thoughts and things that you want to learn about into consideration. So if there's a program, a service, a benefit that you find you are unclear about, you didn't know about, you wanted some clarification, this is your opportunity to really have us provide that additional information in a more structured format. So please let our teams know if there are any topics that you're interested in, and we can tailor our network trainings to reflect that. Our plan, as we did during 2024, is to continue in 2025 with a featured guest speaker at the beginning of the session. And then the agenda for the meeting will reflect regulatory requirements, our own CCHP needs, but we also want to ensure that we're including topics that are of interest to you. So please do not be shy about providing topics for us that you guys are interested in. Next slide. So in order to round out our provider network training, we really want to make sure that you, our providers, are aware of any all plan letters that are coming down through the Department of Healthcare Services and the Department of Managed Healthcare, DHCS and DMHC. At various points throughout the year, our state regulators will update programs, services, and benefits through these all plan letters, and CCHP is required to obviously review these all plan letters, determine any necessary changes in policy or procedure, and also make sure that we update our health plan provider network on any relevant changes as well. Right now, our main regulators are DHCS and DMHC, so we receive all plan letters from them. As we launch the Medicare Medi-Cal Dual Special Needs Plan in 2026, CMS will be another regulator of ours where we need to comply and ensure that we update our provider network accordingly. So next slide. So what we've done is we've compiled all of the APL updates since our last provider network training. So that way you guys can be aware of all the different things that have been in the pipeline and are in the pipeline. This information will also be included in our provider bulletin that is sent out quarterly as well. For those of you on this call who are not receiving the provider bulletin, please do let us know, and we can add your email address to our mailing list for the provider bulletin. And simultaneously, if you know of anyone who is not getting the invites to this provider network training, please let us know as well. We really want to increase the attendance for these meetings. That way we can reach a larger amount of people regarding any important updates or changes. So for our APL updates, these are ones that have been published in late 2024 and early 2025. We have received additional guidance from the state on our diversity, equity, and inclusion training program requirement. You, our provider network, will see us launch this diversity, equity, and inclusion training to our providers in the upcoming year, and this will be a required training for our provider network. And it'll also be helpful in, hopefully informing your care. We also have been asked by DHCS to conduct a transgender, gender diverse, or intersex cultural competency training for our staff. So that has already been launched within the CCHP staff, and we will be making necessary provider directory changes as required by the state to comply with Senate Bill 923. 2418 is an APL that talks about medical loss ratio requirements. 2419 goes into detail on minor consent requirements for outpatient mental health services to minors. It delineates how we as a health plan need to approach minors when they are accessing services that may or may not require parental or guardian consent. APL 25002 talks about our skilled nursing facilities and the quality incentive that applies to our SNF providers. And then APL 25003 talks about how all Medi-Cal plans in the state of California are required to launch a Medicare Medi-Cal dual special needs plan in 2026. So this APL gives us guidelines and requirements. Next slide, please.
Getting a pause real quick for some weird reason. So give me 1 second. I'm having some technical difficulties. I
problem.
apologize.
Yeah, I can go over some of the additional APLs. We also have APLs coming from the DMHC, and some of the APLs that they talk about are how we need to do our provider appointment availability manual survey, how we need to launch the Children and Youth Behavioral Health Initiative. And also one of the big APLs that we get from DMHC are timely filings, which reflect all of the state and assembly and Senate bills that have been passed by the state of California in 2024. As a managed care plan, we are required to abide by these bills. So this requires us to make necessary changes in our policies and procedures throughout the organization. And so as we make those changes, we'll definitely make sure that information is passed down to you, our provider network. They also shared an APL regarding the Southern California fires and how those health plans down in Southern California need to pivot to be able to continue to provide services and care for Southern California Medi-Cal members. Next slide, please. As part of the provider network training, we'll also provide this regular reminder on CCHP linguistic services. Next slide. So as a reminder, CCHP does offer telephonic interpreter services for our members, and these are the general instructions that our community provider network needs to leverage when wanting to utilize these telephonic interpreter services. It's an 866 number. You need to provide a client ID, and then you need to indicate the language you need or press. We offer a large variety of languages, and as Contra Costa Health Plan is part of a much larger integrated delivery system here in Contra Costa County, we're able to leverage that and utilize an interpreter service that really covers the gamut of languages that our membership needs and utilizes. So it is a wonderful telephonic interpreter service. In my former practice, I used to definitely use this interpreter service for my CCHP patients rather than my office's interpreter service, because this was much more broad and much more accessible, and interpreters were much more available. You do need to provide information about the patient to be able to access the service, and they can be used anytime when you or your staff encounter a CCHP member in need, either in person or on the phone, and you need an interpreter to help facilitate the conversation or the visit. Next slide. We also have in-person, face-to-face interpreter services available for members in these particular situations. We do need to have at least 5 business days notice to be able to arrange for this. And so there's an online interpreter request form and a telephone number that you can call. We also have a virtual interpreter available for telehealth appointments. And in order to access that, you would need to email this email address on the screen. This slide deck will be provided to meeting attendees today, so don't feel like you need to jot these down right now. Once you get the slide deck, this will easily be at your fingertips to access. Next slide. We also support translation of documents. So if you need assistance with translating documents for your CCHP patients, our members, please email cchp.quality@cchealth.org with your document. Please have them in Word version, remove PHI, and encrypt if it does include PHI. And then we'll be able to support you on that as well. So just wanted to give you guys some basic information about our interpreter services because we do have a large non-English speaking population in our membership, and we want to be able to support you, our providers, in caring for those members and ensure they get equitable care. Any questions on the APLs or the interpreter services? Great. I would like to open this up right now for if there are any questions that you guys, our providers, have. If we're not able to answer those questions now, we'll be happy to take those offline and provide follow-up at a later time once we can access the subject matter experts within CCHP. All right, well, I think everyone is very easy today. So thank you for attending our provider network training. We will be planning our agenda for Q2, and again, would welcome any feedback, any topics, any suggestions for future provider network trainings. But thank you so much for attending.